In this review of diuretic drugs, you to encourage, I would like to encourage you to review the function of the kidneys, particularly in terms of the nephron, which is the primary unit of the kidneys in terms of functions and how it works in balancing fluid and electrolytes. So it's important to know the different parts of the nephron, starting with the glomerulus, the Bowman's capsule, the proximal distal convoluted tubules, the Henle loop of Henle, and the collecting duct. So you can kind of place these different diuretics in order in the nephron by itself. If you play yourself a visual image of the nephron. So one of the main goals for diuretic drugs, as the name indicates, is to cause diuresis. So diuresis meaning to increase, um, excretion of urine and excess water in the body. So if you want to remove water and excess sodium, the one of the goals could be to reduce blood pressure. So when we give patients such medications, it's usually given to treat their high blood pressure. And sometimes some medications can be given to treat heart failure and some types of edema that's caused due to renal or hepatic diseases. Sometimes some medications, such as osmotic diuretics, are given to treat IOP, meaning increased intraocular pressure, or increased ICP, that is increased intracranial pressure. Just keeping this in mind and the function of the nephron itself in terms of fluid balance and treating heart failure, hypertension, and renal failure. The different classes are loop diuretics, potassium-sparing diuretics, thiazide diuretics, and osmotic diuretics. So for each of these classes, I've itemized the different areas in which it acts. The loop of Henle for loop diuretics, collecting ducts and distal tubule for potassium-sparing diuretic, distal convoluted tubule for thiazide diuretics, and more proximal convoluted tubules for osmotic diuretics. So that's important to know. And also remember that anytime wherever sodium goes, water goes as well with that. There are some medications that try to prevent that. Again, osmotic diuretics, it just helps with removal of water and not the electrolytes, but not so in cases of loop diuretics or potassium sparing or thiazide diuretics. So focusing on each class, in the first class, it's a loop diuretics. The common medications are furosemide, bumetanide. So the mites and the nites, if you want to remember those suffixes, those medications are given to treat heart failure, hepatic renal diseases where there's fluid excess there as well. So the way these drugs act is by reducing peripheral vascular resistance. That's why they're given for blood pressure. And they increase prostaglandin synthesis, renal prostaglandins. So it's kind of protective too for the kidneys. And that's the reason it could be given for renal diseases. And one of the major side effects of this drug is hypokalemia. And sometimes patients also complain of tinnitus, that is ringing in the ears, or blurred vision, and sensitivity to light, that's photosensitivity. And so some of the things that you need to watch for is definitely potassium levels, because potassium levels can cause cardiac dysrhythmias. Also to remember that if patients are on lithium, which is a bipolar, medication for bipolar disease, then that's another thing to keep in mind. So the next class of medication is potassium-sparing diuretic. We've reviewed this earlier, spironolactone, when we talked about drugs in heart failure. So the way it acts is by it is by blocking the the aldosterone receptors. So as you know, aldosterone is important in terms of fluid-based balance through the RAS system by helping with removal of potassium, but it keeps the sodium and water in times of dehydration. However, when patients have high fluid in the body, if we give a drug that blocks these receptors, what can happen is the reverse happens, right? So the sodium water leaves and potassium is kept inside. So again, when potassium is kept inside, the risk is hyperkalemia. With hyperkalemia, patients can have tall peak TVX. So again, cardiac dysrhythmias is possible. So watching the potassium levels becomes important, and make sure they don't take any extra potassium. And it cannot be given for patients with acute renal chronic renal failure. Anytime patients have high potassium, regardless of their cause, this cannot be given. Other side effects of this medication particularly are gynecomastia, but other than that, it's usually well tolerated. And when healthy people without any condition, like other underlying comorbidities, if they just have heart failure, they could be placed on this drug. However, I do know it's a little bit more expensive than the loop diuretics and thiazide diuretics. So the next class of drugs are thiazide diuretics. The name is hydrochlorothiazide. You see that chlorothiazide, right? And the metazolone. So these drugs work on the tubular. They inhibit tubular reabsorption, and they work on the distal convoluted tubule. So they promote natriuresis and diuresis. Natriuresis meaning they get rid of sodium and water. And along with these also go other electrolytes like potassium and chloride. So from that, you know that there's a possibility of hypokalemia. So when you get rid of the electrolytes, again, there's a risk for hypokalemia. One important thing to know is this drug can cause hypercalcemia. So for patients who have problems with low calcium, this could be a drug that could be given to them. So it keeps the calcium, right? Let's say a patient has osteoporosis or other unknown idiopathic reasons that they cannot keep the calcium, then these drugs could be good because it keeps the calcium. Hypercalcemia can be caused, and hypokalemia is the other side effect. Photosensitivity, not as common, but some patients do have hyperglycemia, increased sugar levels, but again, not very common. So this is one of the common drugs that's taken. Like any diuretics, it's important to give these medications earlier if possible, not late in the night. Maybe talk to the healthcare provider to place it in a time that the patients will not have to use the restroom at night, and to ask them to call for help if they want to go to the restroom, not to just walk by themselves and take a fall. So the last group of drugs that's really important in terms of knowing this as a very potent medication for increased intraocular and increased intracranial pressure when patients have tumors or seizures or traumatic trauma and head injuries. This medication can be given where we want rapid diuresis of the water, particularly without removing the electrolytes. So what these drugs do, the mannitol is an osmotic diuretic. They're kind of like, like the starch. It's a starch. If you think of starch, it's like rice. Rice has, rice, sugar. These all have starch, right? So what they do is they just absorb like a sponge, pretty much the extracellular fluid, the fluid in the cells, and they expand the extracellular fluid, which increases the blood flow, and then through the proximal convoluted tubule, the water is just excreted. So one thing to keep in mind is this medication can cause pulmonary problems like pulmonary congestion because of the fluid sudden, shift. And then thrombophlebitis is another possibility, particularly when we give IV infusions. There's also some interactions with anticoagulants and statins, so caution when patients are on those medications. One of the important thing is to know that these medications are given only IV, mannitol, so we got to infuse very slowly, and because it can crystallize, so we need to keep them in the warmers, to keep them warm, because just like sugar, it can crystallize and it's very cold, and especially in a fluid form, right? As far as potassium sparing diuretic, teach patients to avoid potassium rich foods so they don't keep even more potassium, which can cause cardiac toxicity. So these are other things that you have to teach. So please refer to your book for further info.